pass, and then we'll, if we may, we'll get going. See, we're being recorded.
Okay, all right.
Okay, I think if we may, we'll get started. I hope you've all been able to see the agenda. We've got some interesting presentations this morning, so look forward to those. Can we just start then with welcome and introductions? Well, welcome to everybody. I don't think there are any new introductions unless I've missed someone out. Apologies for absence, Julie.
Yeah, we've got apologies from Gillian, David and Natasha.
Okay, thank you for that. Any declarations of interest in the business, please? No. Okay, thank you. Minutes of the last meeting are held on the 29th of July. Any corrections to the minutes, please? No?
Yes, yes.
Oh, right.
Sorry, hi, it's Debs Edwards, Councillor, Reading Borough Council. Yes, I was left off the attendance.
Oh, I do apologise.
Yes, so if you can just slip me in there, that'd be lovely. Thank you.
We'll do that, certainly. Thank you very much. Anything else? No? Okay, I don't think there are any matters arising unless anyone has found something that I've missed. No? So could we then move on straight on to the external auditor's report to the Council of Governors? I'm going to invite Deloitte to speak, please.
Thank you, Chair. So our audit and our process audit this year has been rather different to in a normal year. Clearly, it's very much affected by the COVID pandemic. So in March, there was a decision taken by NHS Improvement to remove the requirement for the quality accounts to be included within the annual report and to remove the requirement for the external auditor to perform procedures on that. So the report that we would normally present to you, setting out the findings from that work, is not amongst your papers. That work has been out. For the financial statement audit, clearly it was a very unusual circumstance with much of the finance team and management personnel moving to offsite, working just before the end of the financial year, and the external audit being conducted entirely remotely. What you have before you is our enhanced audit report that's included in the annual report on that financial statement audit, setting out the risks that we had principally focused our work on. That's not to say that we hadn't tested other items as well, but these were the areas that we had identified as being what's called significant risks, and so requiring additional, more detailed scope of work, and requiring us to report upon them to the audit committee and to report to them on them in our report, in our audit opinion. As you'll see on the first page, we issued a clean audit opinion, so we did not qualify it in respect of any matters, but there is a particular point we will draw to your attention, which in old terms would have been an emphasis of matter, drawing attention to things. So as I go through on the second page, with respect to going concern, there were no issues arising from that and have nothing to report. And the key audit matters or areas of significant risk we focused on were property valuation, where you'll see that, and this was a risk.
Benjamin,
yes.
Benjamin, I am sorry to interrupt you. Could I ask everyone who isn't you to mute themselves, because there's a lot of extraneous noise on here.
So of our significant risks, property valuation, this is a risk in previous years, but you'll see if you look at the text, it's quite different in what we've discussed in the context of COVID-19. So in March, the Royal Institute of Chartered Surveyors issued a valuation notice to the surveying profession, effectively indicating that for almost all types of asset, those valuers should consider whether there is a material valuation uncertainty affecting their valuation. That's not to say that the valuer couldn't take their best professional view of what that valuation was, and that's what they did in reporting to the trust. But it means that the inputs to that valuation are more uncertain, and the kind of range of valuation is more uncertain than it might normally be. And so that is reflected in the disclosures that the trust has made within the financial statements itself, and we've referenced that in our opinion. And if this was a sort of what's called not an enhanced audit report, so not having this level of detail in, then we would have included an emphasis of matter drawing attention to that, because it's just a matter of such significance at this year end. The other significant risk we felt we highlighted here is management override of control, which is a required risk on all audits, and which is therefore not included because there is a specific area of concern, but there are areas we have to look at on accounting estimates and key judgments that are reflected in here. We also performed some closer testing on accruals and completeness of expenditure, but that wasn't of sufficient significance to be included in the audit opinion itself. Does anyone have any questions about our work or our, sorry, final thing I should say, clear in respect of value for money and the arrangement where the scope of our work is considered the arrangements that the trust has to secure economy, efficiency and effectiveness in the use of resources. We conducted our work that we're required to do to assess if that we consider there's a significant risk there. We didn't identify any matters in that regard, and we therefore have no matters to report in our opinion. So, hi Chair, I think you may be on mute.
I am. Thank you very much, Ben. Any questions, please, for Deloitte?
Martin, it's Chris. Can I just make a quick interjection? Just to say, as Chair of Audit, obviously big thanks to Deloitte's internal audit and counter fraud for, should we say, coping with us during this difficult period. And just to clarify to governors, whilst in commercial organisations there might be something to be gained by manipulating property values or etc., there is absolutely nothing to be gained in an NHS environment. But there are always, because there are, should we say, there's more than one valuation approach, there are significant uncertainties right now, there is more than one valuer. It's quite possible, as Ben said, he's not raised anything that isn't, should we say, totally normal. In our particular circumstance, if we, should we say, deliberately depressed our asset values, it might mean that we paid slightly less as a, should we say, charge on capital to the Secretary of State. But other than that, you know, there really is nothing for to be gained by any gaming around property values. So clearly, it's not something we set out to do.
Okay. Thank you for that, Chris. Any other questions? No? Ben, thank you very much indeed for the audit. It's a satisfying result. Thank you. I think we need to ask you to leave now because we're going to move on to appointment of external auditors.
Thank you, Chair.
Thank you very much for your time. Enjoy the rest of the day. Okay. Could I invite Alex, please, to speak to external auditors procurement?
Morning, everybody. Yes, and it's just to give a heads up, really, to governors who have a key role in appointing our external auditors. Could we all go on mute, please? Thank you. That our contract with Deloitte comes to an end in March 2021, and so we need to start our procurement exercise to appoint a new auditor pretty soon, actually, in the next month or so. There is an opportunity with the Berkshire, Oxfordshire and Berkshire West integrated care system to do a collaborative procurement for external audit. And I've spoken or contacted with Paul and Julie that we might have this opportunity. I think it's one we should have a look at, as well as potentially the option of going out on our own. The benefit of going with the integrated care system is we're likely to get a sustainable response from audit firms. There is some concern that audit firms are withdrawing from the NHS. And we would also be able to push a bit harder on value for money in terms of the audit fee. So I just wanted to log that, see if there are any concerns about that approach, but reassure you, from my perspective, is here a sensible option to look at.
Okay, Alex, just to remind us of what the timescale is again when the governors have to choose new auditors.
So we need to reappoint by the end of March 2021. And I expect we'll be able to get the timetable together to begin that in the new year. But I just wanted to identify we could start a process just before Christmas with Bob ICS.
Okay, Paul.
Yes, this is quite interesting for us, and I'm not sure what the benefits are, but maybe the one that I've heard of is that we'll have more people applying to do a joint audit of all parts of Bob than we would for just our small trust. But on the other hand, we may be in a position where the Bob wants to go with someone and we don't. But I don't think we'll probably have that option. I think it's probably all or nothing, isn't it? Either go with Bob or don't go with Bob.
Yes. I would expect the process to weed through to the best auditor for all partners in the ICS, and we would involve governors and Chris's audit chair in that process to ensure that our voice was very clearly heard about what was important within the specification. The key thing will be agreeing the specification up front.
And to be clear, we don't have any problem with Deloitte.
No problem at all.
And the only problem with the prior auditor was the fact that they wanted to act as business consultants to us.
That's right. There needed to be a division in terms of their firm from audit services to advisory services.
So if they chose, if Bob chose, I've forgotten what they were called, our previous auditors, and they were continuing to operate as business consultants, then we'd have to just change our business consultants.
Yeah, we'd be mindful of that, and actually we're using very little now of KPMG as advisory for the QI program, so that need is tailing off, and we have a clean slate, as it were.
Okay, just to say, Paul, of course it is for our governors, that is you, or to make the decision about external auditors. I think what Alex is highlighting, there's an option as to how we go about making that decision. But we can't have auditors forced upon you, and the governors have to make that decision. So your arm isn't being twisted.
So what I can do is explore a bit further with Bob and come back to you, Paul, and governor colleagues about a recommendation on that, and we can take a view. I'm very happy to go individual procurement route if you're not content. But at this stage, I can see benefits around sustainability of offer to the system from audit firms and potential value for money.
Thanks, Alex. Tom, I think you've got a hand up. Tom Lake.
Yes, thank you. I appreciate the points that Alex has made. I just want to raise a caution. Would we be under pressure to change the format of our quality accounts or our main report and accounts in order to meet, or even some of our internal monitoring in order to meet the requirements having common auditors?
No, we wouldn't, Tom, because any external audit firm audits against common reporting standards, both for the quality account and financial accounts, which we have to follow as a foundation trust.
Okay, thank you very much. If there's no more questions for Alex. Yeah, okay.
Thank you.
Thanks so much, Alex. Can we move on then to item 7, the annual report and accounts, and invite Julian to say a few words on the annual report, and I think Alex is going to come back on the accounts themselves. So Julian, over to you.
Yes, thank you. Is Julie or Jenny just going to put the presentation up? That would be good. The first, when you do that, if you are able to do that, just go straight to our priorities and true north. So this is a very, very succinct review of the annual report. It's obviously published. It's a very long document, as is the quality account. Both of them provide a lot of detail that I'm not going to go into today, but just give you a flavour. This presentation is also the same as I give at the AGM because I've got the same task to do. It's just that I'm going to skip through the first 3 slides because the first slide tells you about Berkshire Healthcare, because people at the AGM often turn up and get confused with the other trusts. And then the next 3 slides are ones I showed last time, which are around our CQC rating, which obviously was the most significant thing in terms of external review that we had during the course of the last year. Majority of the year under review doesn't take into account effectively the lockdown and the COVID period. It was obviously towards the end, the last few weeks of the financial year. So a lot of the work I'm referring to was effectively the kind of pre-COVID period. As I say, we can just move on through those first few slides around the CQC because I've already shared those with governors last time. And we'll be obviously using them at the AGM. And take us to the slide with our true north, our priorities true north on it. That'd be great. And the next slide. Next slide. Next slide. There we go. So in a nutshell, very simply, our priorities for last year: harm-free care. First rule of healthcare: don't harm your patients. Improve staff experience, improving patient experience and outcomes, and supporting financial sustainability. So a few sort of hard measures of that, which I can report on. So we had a target of no more than 18 category 3 or 4 pressure ulcers for the year due to lapse of care. So pressure sores or pressure ulcers. Go back 10 years, there would be hundreds, particularly on elderly people's wards, end-of-life care, etc., etc. Year in, year out, we've managed to reduce it with some wards not having any all year. And we've been able to achieve that target. So that stretching target of reducing the numbers was achieved. Reducing the falls to no more than 4 per 1,000 bed days. So 1,000 bed days is a lot of bed days. And again, we didn't quite achieve this, but we've got a reducing trend. And to be clear, we've stretched ourselves every year around the de minimis sort of target. We've actually reduced our level of falls on our inpatient areas by 50% since financial year 18-19. And we've still got a downward trend, but we haven't quite hit that 4 per 1,000 bed days. If we did, we'd probably be the best in the country. So, and that was the ambition, but we're pretty close. No more than 4 medication areas in moderate harm for the year, so not even severe harm, but moderate harm, and we achieved that. Electronic prescribing is a real helpful asset there. Reducing the rates of suicide of people under our care by 10% by 2021. That's been a 5-year target, and we're on track for that. So it's against the 2017-18 figures, and we're absolutely on track. And all our services will contribute to an outstanding CQC rating, and as you know, we achieved that. So the next area is around our staff experience, and we've actually made some real inroads this year for the first time. We've made slow progress the last few years, but on some big targets. So at the end of the financial year, our staffing situation was the best it's been probably for a decade. Not perfect, not where we want it to be, but significantly better than this time last year. And some examples of that, we said we wanted to keep our vacancy level for the year below 10%, which we'd had a struggle with in previous years, and we achieved that with some headroom at 5.9% in March, and that is continuing to decrease. Our staff turnover in healthcare is the highest in the Thames Valley of anywhere in the country. So we're in an area where there is naturally high staff turnover, high cost of living, people are able to move around more freely. We had been running at 17% a couple of years ago. We set a target of 16, and we've got it down to 14.9 at the end of the year. Still too high for us, and it's still a real focus. But again, it is coming down slowly, as we know, through the first 2 quarters of this year too. Our annual staff survey, so in terms of satisfaction and engagement, what do the people who work for us, the 4,500 people, think about Berkshire Healthcare? We are top 3 in the sector in terms of high levels of engagement, satisfaction and motivation, a position we've maintained for at least 7 or 8 years now, so it's a consistent position. But we recognise we've got more to do, particularly around colleagues with a disability, declared disability, and our BAME colleagues who continue to report a less satisfactory experience of working at Berkshire Healthcare. And a reduction in patient to staff assaults. 80,000 people in the NHS were assaulted last year in the NHS, which is terrible, and that's massive under-reporting. Services providing mental health and learning disability services are right at the top of that. We didn't achieve our target again, which was stretched, but definitely a downward trend, so our trend line is down, and we were below our target for 7 out of the 12 months in terms of below the 36, and Sorrel Ward and Campion Unit making big inroads, and that's where the greatest assaults take place in those wards. Patient experience and outcomes. We've got a new friends and family test coming in this year, which I think will be better, particularly for mental health. It doesn't ask, would you recommend, mental health services or your experience in psychiatric intensive care to family and friends. It never really landed well, so I think that will help with our lower score in mental health inpatients. Ask more about your experience. But community inpatients and minor injuries have continued to really have high levels of satisfaction. Our mental health inpatients are about average. So all mental health services, because of what I've just explained, tend to have lower levels of satisfaction. And Berkshire is about average. So we've got some work to go. And Natalie has previously reported on our work to improve our experience and also capture experience. Reducing delayed transfers of care. People actually stuck where they need not to be. It's not good for them. Keep it below 7.5% of all inpatients. We've done that. And reducing cases of prone restraint, the most dangerous element of prone restraint, face down. We had a presentation to governors about this previously and to the board. We didn't achieve that, but we've gone from upper quartile in terms of use of prone restraint to lowest quartile nationally, and we did achieve that target 6 out of the 12 months. Next slide, please. Financial sustainability. We achieved our financial plan for the year, and I will say no more because Alex will follow on immediately after me, so he will do it better than me. 2 last slides. So if we look at the rise of online consultations, now, unlike the rest of the NHS, Berkshire Healthcare pre-COVID was already doing online consultations, but you probably can't see on your own computer screen. I've got a bigger screen here, but the main box at the bottom, which says one consultation and MS, Microsoft Teams online consultation activity. In January, we had 102 online consultations with patients, 101 in February. This is excluding telephone consultations and purely digital. This is using things like Microsoft Teams and our one consultation bespoke outpatient digital platform. And then in March, it rose to 3,000, and clearly that was right in the last week or 2 of March. So the technology that we'd already invested in came into its own, and then 15,000 a month in May, 16,000 or so in June and July, tailored off slightly in August as we started a bit more face-to-face. But you get the message that actually we started to use technology at a scale to engage with patients, and we engaged with staff and patients around their experience of it, which are the 2 pie charts. And on the whole, people were satisfied or very satisfied in the majority of cases with the online consultations. So a significant breakthrough, a transformation that actually we've been working on for a few years, happened overnight. And most of our teams are saying that they will return to some element of face-to-face and a blended approach, but many will be flipping what they were previously doing. So probably 80 digital, 20 face-to-face, other than, of course, inpatients and some of our crisis services will remain predominantly face-to-face. And my final slide is it's not just been for patients, but also if you look at the next slide, you can see that the organisation, this is the use of Microsoft Teams in the organisation, Microsoft Teams usage for either team meetings, which are the orange bars, or a team call, a one-to-one call with your colleague. And again, at the end of the calendar year, Microsoft wrote an article about Berkshire Healthcare and about the uptake of Teams in the organisation. So at that point, we were using about 2,500 Teams calls and about 2,000 Teams meetings a month. So this is pre-COVID. And Microsoft wrote about us because we were way ahead in the NHS. So we were well prepared for what's about to happen. And then, as you can see from the graph, we've started to use Teams in order to operate. And we've saved about £500,000 so far in travel. That's this isn't patient travel, this is staff travel, travelling for meetings, £500,000 during the course of the year. So huge impact on the environment, huge impact on efficiency, huge impact on flexible working. We've surveyed all of our home working staff, 2,000, and about 90% want to carry on and work in this flexible way. They think it gives them a level of flexibility and job satisfaction they've not seen before. So if we think about looking forward, there is no doubt that digital offers us our biggest transformational opportunity, both to offer choice to patients, both during the pandemic and after it, but also address some of our workforce issues and efficiency at work issues on a scale that, frankly, we would have thought unimaginable outside of the pandemic. So something to look forward to for the coming year. I'll leave it there and hand over to Alex for the financials.
Thanks, Julian. Julie, if you could stop sharing, that'd be great. And I'll just share my slides. Thank you. Okay. Hopefully everyone can see that. So we're looking at the financial review for 1920, so the year to the end of March 2020. You can see in the bottom right-hand corner our accounts reported surpluses for the year 1819 and 1920. Actually, I need to correct that slide for the AGM on 1820. What I'd characterise in terms of the comparators to the prior year is that we had a higher surplus mainly because of bonus central funding we achieved due to achieving our control total as set by our regulator, NHS Improvement. This year's surplus margin is slightly smaller. Pre the asset impairment that I note in the first bullet here, which is a change in values of some of our assets, our underlying surplus was in line with plan. And again, we achieved our control total and achieved our full payment of central bonus funding for that control total. So, as Julian said, we delivered our plan against that £276 million of revenue. Within the overall financial position, we had a good year actually in comparison to previous years around our cost savings delivery. All of that £4.6 million saving was recurrent savings, where previously we had a mix of recurrent and non-recurrent actions to improve the cost base. Recurrent savings means we get the benefit year on year into the future of that saving, which is really good. Although we had a slight increase in our temporary staffing costs to support the operation, we did in fact reduce expensive agency by 1.1 million of spend, again really pushing down on the use of agency within the trust. And as we know, agency workers don't necessarily support high quality care. We're wanting to recruit as much as possibly we can substantive staff, and we've seen that coming through in some of the workforce results as well as our own bank staff. From a regulator perspective, we returned a risk rating of 1, which is the lowest financial risk rating you can achieve and gives a view of our overall financial stability and sustainability going into future financial years. So another strong year for 1920. This is our balance sheet, highlighting an improved and strong cash position in terms of liquidity. A very good impact of 10.3 million, one of our highest spends on capital investment to date across our estate and technology, and really pushing on the areas of our global digital exemplar. And Julian's just shown you some of the IT infrastructure investment around Microsoft Teams and our network that has allowed us to flip and shift to a whole new way of working in very significant terms. So that's been excellent to have had that investment in place. Those are the highlights of the financial year. I'm very happy to take any questions on that. Thank you.
Thank you very much, Alex. Can we just start for questions for Julian, and then we'll come on to the finance if we could. So any questions for Julian from governors? No, everybody happy? Linda.
Yeah, just a couple of comments really from me, because I'm probably interested in transfer of care, especially as COVID continues, especially transferring people to care homes, and in particular, my interest is. Sorry, I've got a lot of feedback on the line, so I don't know whether it's me or whatever.
People need to go on mute, I think.
Okay, that's better. Yeah, transfer care. So I'm interested in that, especially ongoing, and what that means, especially with transferring people into care homes or any other form of care. My interest lays a lot with dementia, and I'm very concerned that there has been the detriment of COVID on people with dementia. And I think I was also interested in the digital. While it's great to see how we can all use digital going forward, it's about those that can't use the digital and how they will be included, so that we're not digitally excluding people. Because some people may need more support, and how is that? How do you ensure the confidentiality of patients as well through that? So they're just some things I sort of highlighted. So I think great results to see how Microsoft Teams is being used, but I'm still worried about some of the bits and pieces there with that.
Yeah, thanks, Linda. Great question. Actually, I should have probably covered off the kind of digital exclusion issue, because it is something we've been thinking about. So it's very clear that in the area of the country we serve, we have high levels of digital inclusion, and we should make the most of that. And I think that's really important. And as you can see, we're able to get to high numbers. That should mean that we should be able to address the levels of digital exclusion, particularly at system level. And so we have started to do some work on this. Alex, I don't know whether you want to just comment on some of the thinking that we've been doing. So we've run some pilots, Linda, to see how we might tackle this at a small scale, so we can build it up. So it has been something that the teams have been particularly working on. Alex, do you want to say more?
So taking older people's mental health services and the memory clinics and dementia services as an example, in Berkshire West, the teams have been provided with iPads, and where the family or carers are able to support the individual with needs to connect digitally, they can do that. But also, really importantly, within our recovery of service models post-COVID, it's fundamentally important we identify where access may have been restricted because of the digital model. And older people's mental health services in particular have identified a service model that says we will go and see you in your home, or make face-to-face arrangements where necessary, where digital isn't appropriate. So it's going to be about experimenting with the digital access, but also ensuring we've got face-to-face care happening where it's absolutely needed. And we have, and we're looking forward to seeing how those pilots work and getting patient feedback on it. But as Julian says, in terms of digital poverty and access to 4G mobile data or internet, it's actually mainly focused into areas of Slough. So the Slough teams are very cognizant of that as we're working with our services there.
And sorry about feedback again. Alex, can you unmute? The other thing, Linda, is quite a lot of our services continue to do face-to-face. I was with our crisis service in the East. They're doing telephone triage and face-to-face. It's some of those services, say for young children, where the wearing of PPE and they're assessing communication is quite difficult, obviously, as those. In terms of care homes, a lot of the care homes, and I'm getting my information from our care home InReach team and our community nurses, who I spoke to again just last week in detail. They have been, a number of them, quite badly traumatised by the experience of the first wave. They were the last to get the PPE. They felt that they took the brunt of the discharges from hospital, and whether that's true or not, the stats don't always bear that out. It's certainly how they felt. We provide quite a lot of support to those care homes through our InReach services and through community nursing, although a number of them are declining support from community nurses, because our community nurses are obviously going to so many homes, and they at the moment have instigated weekly testing for staff in care homes, which we haven't got in the NHS. And again, we've got sort of in fact, we've ramped things up in the care homes, and now they're a bit wary of our NHS staff, which is a shame, because as you can imagine, the skill set of some of our community nurses and community matrons is high. There is a level of trust, and we're working through that, but there's no doubt that care homes will continue to be a focus of work for us. and there was lots we didn't get right as social care and NHS bodies over that first period that hopefully we'll learn from this time. Thanks, Linda.
All right,
Thanks.
thank you. Can I just come in? Sorry, one other bit there. I suppose, you know, because I get everything that you're saying and I understand the great work that has gone on, I suppose, but with going and looking more digital, I suppose I'm also worried about the impacts that has on, you know, individuals that you know, socially isolated as well. So it's about all that and the considerations around all that come into play.
Yeah, I think that's right. I mean, you know, there's going to be an element of choice, Linda, isn't there? You know, when you go to the supermarket, a lot of them now, you can either go to the checkout or you can self-serve. And I think that, you know, as we move forward, there are some people, say, for example, in our talking therapist service, the age group and everything else, they're very comfortable with the digital offer, as are the staff. So we'll see high numbers of that. I think, you know, in our memory clinics, majority is going to revert back to face-to-face because for the initial assessment, and then subsequent assessment will be a conversation between the clinician and the individual. And again, you know, it's interesting, we can make assumptions, but older people generally are liking the digital because they really dislike the car parking and the travel and the hassle and stuff. There's some things they dislike, so we make some assumptions sometimes that are not borne out, and we've got some good evidence of that because our one of our teams, our dietetics team, did some research about 2 or 3 years ago on digital appointments. So again, it's important we don't get stuck into stereotypes and actually work on a person by person basis with this. But I suppose the point I'm making is the size and scale of digital, the genie is out of the bottle. You know, we won't be going back to, you know, just a few hundred digital consultations ever again. It will be in the many thousands. And that offers huge benefits because it means those people perhaps who need face-to-face, we can give them longer and more personal attention. It means we spend less on buildings and more on people. So there's some real upsides to it too. We're just going to get the balance right.
Thanks so much. I think Tom's been very patiently waiting. Tom Lake.
Sorry, just unmuted. So I've got a couple of questions, and you might say it's not. We ought to do it in a different meeting, and that'd be fine. So the first one relates to the way we set priorities in the quality account. So the quality account set priorities for the current year, and of course we don't know if that's all been blown out of the water now. But the point I want to make is a bit longer, is the way the clinical effectiveness priorities are set. And it's a point I've made before, we've discussed it between us before, but to say I would be very gratified if it were possible to start introducing outcome measures in the clinical effectiveness priorities. So that's sort of looking ahead to 21-22. When you think about priorities for 21-22, will it be possible to introduce clinical outcomes measures? So yeah. So
Julian, are you happy?
Yes, conversation we had before, where we can set them meaningfully within a 12-month period, yes, but there will be some services that will be difficult to do that in the course of a year, and therefore there's always likely to be some proxy indicators for some. A, because the length of treatment will be over a year, and B, you know, some of the factors are outside our control. Someone with severe mental illness and substance misuse issue, it's quite difficult sometimes to set a very clear target, unlike a hip operation, for example. So there are some of our services like IAPT that have clear outcomes and can be nationally benchmarked. So of course we can do that. But some of the targets, as Alex said on the external auditors bit, are set by the regulator, and we just have to follow those. And I think that was the conversation I seem to remember having at the last governors meeting when we were setting the priorities. The governors felt slightly constrained about the conversation. That's because there's national. So Minu and others can take that on board and perhaps work that up with governors. Thanks, Tom.
Yeah, so I perfectly understand it's like the start of a long journey, I'd say. It's only the start, but it would be, you know, it's a good thing to start, I think. Thank you. Can I get another question, or is it a quick one? Well, maybe we should do this at the next meeting, but I've been completely, you know, wondering how the inpatient mental health wards could operate during the lockdown, and just to get a picture of how that worked. They're sort of little closed communities in some ways, with the staff coming in and out, and how that actually worked. So maybe it's not. If it's appropriate today, could say something. If not, we'll do it at our private meeting.
No, it's very clear. So the inpatient staff, community, district nurses, everything else have continued to work as they previously worked. At the beginning of the pandemic, Tom, the numbers in our inpatient beds was relatively small. So we went down to about 60% occupancy, but since about June, mental health inpatients have been full. At Prospect Park, we organised it so that where we had confirmed COVID positive cases, we cohorted them on one ward. And that was learning from Italy, because unlike physical healthcare, the patients are mobile, and in Italy they were seeing the spread of the between wards. So we were able to contain it, and we did a good job of containing it on that ward, although it was very tough for that group of staff. Obviously using PPE and managing infection control in the classic way. So we were testing patients, and any suspected cases or confirmed cases were cohorted on a particular ward. The other wards continued pretty much as was. There was some curtailment of activity. Obviously, can people go on mute, please? That's helpful, thank you. Yeah, so some of the activities, particularly outside activities, just like the rest of the world, were shut. But staff effectively had to don PPE. Now, in an environment where communication is key, I did wonder how that would land. But actually, my observation of going to the wards was that people have just accepted it, particularly now because people have been admitted from wards when they've been used to people in supermarkets and all the rest of it with face masks and everything else. And inpatient colleagues have just got used to that way of working. So it's pretty much the same standard of care, pretty much the same activities. The biggest difference is staff wearing PPE and taking infection control measures, and obviously testing suspected patients and cohorting where necessary. But we've got a lot of echo again. We've got no COVID positive patients in any of our inpatients. That's community hospital or Prospect Park at the moment. I suspect that will change in the coming months.
Well, thank you. Congratulations to all concerned on the containment. That really is very impressive. Thank you very much.
Thank you, Tom. We've got three more. Arlene, Mavis and Isabel. Could I just ask you to be fairly quick with your questions, please? Arlene.
Hi. Yeah, though it was a quick question. It was actually picking up on Linda's point, and it was really just musing on the because I represent the university, thinking about skills and expertise that we have with digital in terms of particularly older people, and whether there's any contribution we can make to supporting the efforts in terms of evaluation or sharing some of the practice that we've got experience with, just for reassurance, or support in rolling that out.
Arlene, that's a fantastic offer. Yes is the answer. Would you be able to just provide your details to Alex, and we can perhaps,
sure.
Alex is leading that, so if there's any particular bits and aspects, that would be so helpful.
Yeah, no worries.
And Martin himself has often echoed from his time at university that they were already thinking many years ago about how they deal with digital exclusion in relation to students, and they've been a bit further ahead than healthcare is. So yes, it'd be great to draw on that, Arlene. Thank you.
Thank you very much, Mavis.
I think Mavis is Andrew, surely.
Must be Andrew.
Oh yeah, sorry. Whoever it is. Got the hand up. No? That's Isabel then.
Sorry. Talking about the people being in the wards, etc., during this very difficult time of COVID, how did the patients react by not having visitors, and just as importantly, how did their families react not being able to access the loved one in hospital, please?
Very difficult at times. Sorry, can I ask everybody to go on mute, because it's just, I can't, it's so echoey now. That's good, thank you. Yeah, Isabel, a couple of things. So anybody right from the get-go who was on end of life, family were allowed to visit. We used the iPad, so all the wards had iPads, so they were able to do, and we were obviously able to set it up so that we're able to Skype or Zoom or Teams their loved ones, so they're able to stay in contact that way. And we did get some good feedback that that was a help, but it was tough, you know, for those families, and you know, tough for the wards as well. You know, with the reality of it is the wards rely, don't they, on carers coming in to do some bits and pieces. So it was tough both on the staff and on patients. I mean, there's no other way of describing that. I had a family member in hospital at that time, and it's just, it was very, it's hard, really hard not to be able to do the things you want to do. We've obviously gone back now to test and trace kind of visiting. So visiting is allowed, but obviously not large scale. You have to book the visits rather than just being able to turn up, because that's a requirement of the government. But we have obviously had people having visiting, but not as easily. So that has improved the situation combined with the digital. So it's been one of those areas, Isabel, that's been super tough for families. Don't think there's any dressing this up.
Okay. So, oh, sorry, Isabel, did you have something else?
Thank you.
Okay, thanks so much. Now, any questions for Alex on finances? He always gets an easy ride, Alex. I don't know why. Oh, you got a question, Tom?
There's a category of income, Alex, which is foundation trust, and I wonder if that's our services being paid for by other trusts.
It is, yeah.
Okay, thank you. Yes, thanks.
Okay, John Barrett? John, are you there?
That's better. Sorry, I forgot to unmute. Apologies. Just about the improvements to physical estates, Alex. Obviously, presumably there's been a slowdown due to builders not being able to social distance to do certain things. I wonder how is this affecting our plans to take more control of the community hospitals at all? I mean, I know Wokingham was scheduled to be first. Is that still going to be going ahead, or is it a delayed project due to just circumstances beyond our control?
So I'll just address the question about impacts on our estates programme in general. So one of our key projects, which completed broadly before the pandemic hit, was the development of Early House at the White Knights campus as our new consolidated community service base and mental health service base in Reading. There's a fantastic development there. We just need to complete the car parking in that area, so that's all but done. The other programme that was at risk but has improved in terms of timelines was our move of the Campion unit within Prospect Park to a much improved environment within the main building of Prospect, and the construction team have been able to get back on site much quicker than we expected within the pandemic, so that's good. In terms of the community hospitals, there was a bit of due diligence going on as to whether it would be appropriate for us to take those sites on from NHS Property Services. Having done that due diligence, the business case doesn't stack in terms of affordability, and that's due to strange funds flow that happen between the Department of Health and NHS Property Services that we wouldn't benefit from, so it increases our cost if we took those on. But in the meantime, we work closely with NHS Property Services to make sure we can get the best out of those hospitals. We know there's a big development programme planned in Berkshire East for St Mark's and Upton specifically.
Thanks, Alex.
Okay, thanks, John. I think it's time to move on. Thank you, Julia and Alex, presentations. We've now got a very interesting presentation, particularly for me, about carers strategy from Dan Groves. And I think, Dan, if you're there, we'll let you press on and ask you some questions afterwards.
Okay, thank you, Martin. So good morning, everyone. My name's Dan Groves. I'm just going to try and share my presentation. Hopefully this will work. So hopefully we can all see my slides on the screen now. If you can't, they're on page 32 of your papers. So like I said, I'm Dan Groves. I'm the physiotherapy professional lead for Berkshire Healthcare. But back in December of last year, I started a 2-day-a-week secondment for 6 months as the Care Lead Project Manager. And I'm here today to update on the work completed during this period on revising the Trust Carer strategy and the development of a carer offer. So just to give you an overview of what I'm going to discuss today, hopefully you can see the content of the presentation there. So I'm just going to give you a bit of background information regarding the project and the vision and goals of the piece of work that I was doing, and then update you on where we got to, with COVID throwing a little bit of a curveball in, but where we got to with the project itself. Then discuss a little bit about what is contained within the carer offer and how we came to that decision. And then we'll look at how services would evidence compliance against the carer's offer. And finally, implementation plan and next steps. So in early 2019, a carers workshop was held using quality improvement methodology, and the following vision was created. So the vision for the organisation was that all Berkshire Healthcare services will have a defined carer offer, which is informed, understood and valued by carers. And services will regularly review their offer and provide evidence of their compliance through a process of self-assessment. So in order to achieve this vision, the following 4 project goals are formulated. So there are 4 goals in total. So using national best practice guidance to develop a carer offer that our services within Berkshire Healthcare will be able to provide. Create a methodology to enable services to self-assess what level of carer offer they should implement. Review and revise the Trust strategic plan for carers and try and align that with the direction of travel set by NHS England, the 6 local authorities in Berkshire, and is consistent with NICE guidance. And then looking at how we have a trust-wide implementation plan to facilitate the successful implementation of a carer offer. So firstly, the Carers Task and Finish group was created, and this group was created to make decisions on the content of the carer offer, the strategy and the implementation plan. So this group had representatives from each division and any staff who had a particular interest in supporting carers or working with carers. The second point there was about how we engage with Berkshire local authorities and carer support groups and agencies. So I attended several meetings with the local authorities and carer support groups and agencies to discuss the proposed content of our strategy and the carer offer. Feedback was really positive, and the consensus was that what we were proposing to do would meet the needs of carers and improve the experience when they access healthcare within our organisation. There were plans to attend several more meetings, which were scheduled for April and May, but unfortunately due to COVID-19, these were all cancelled. Despite COVID-19, we were able to produce the following 2 documents, which are embedded into the presentation, but I also know are in your packs. So that's a family and friends carer strategy for the next 3 years, and then a brief overview of the family and friends carer strategy and that kind of documents how Berkshire Healthcare plan to move that forward. So it's a kind of a quick, easy read. So the content of the carers offer. So to give you a little bit more depth now and a bit more detail. So the Task and Finish group decided that a 2-tier carer offer would be the best option. So a tier 1 offer would be the basic minimum that all Berkshire Healthcare services would offer to carers. And this offer contains 3 standards, these being that our staff will be carer aware, that services will identify carers and involved in the planning of care, and staff will refer or signpost carers to relevant support. The tier 2 offer would include all the 3 standards I've just read out, but in addition, there will be another 3 standards. These being that services have allocated staff responsible for carers, services provide an introduction to the service and relevant information across the care pathway, and services provide a range of carer support and obtain carers' feedback. Now, these 6 standards align very closely to the standards that are contained within the Triangle of Care. For those of you who aren't familiar with the Triangle of Care, I'll just give you a bit of a summary. So it's a national scheme that emphasises the need for better involvement of carers and families in the care planning and treatment of people with mental ill health. So it's a mental ill health document, national document. It contains 6 standards again that ensure that family and friends and carers are included and supported by health and care services. So as an organisation, we're already a member of the Triangle of Care scheme, and this approach would complement the work already completed in mental health services and provide further evidence that the mental health services could use to self-assess their continual compliance with the Triangle of Care. So a question that we debate is, so why not just take the Triangle of Care and roll that out to all of our services? And we kind of discussed that at long depth in our carers group. And really the feeling was that many services would have minimal involvement with carers, and therefore trying to make these services adhere to all the standards which they may seem as unimportant or irrelevant to their core service users, we felt would result in a lack of engagement and it wouldn't actually happen in practice. So we thought the pragmatic approach of developing this two-tier carer offer would offer more stimulation and more engagement from services, therefore delivering an overall improvement in the experience carers have when they access services provided by the organisation. So how do we decide what we offer? How do services make a decision? So is it a tier 1 or a tier 2 offer? So really the following flowchart is hopefully quite simple and self-explanatory. It is that really if you're a mental health service, you would just continue and offer the tier 2 care offer because that supports the triangle of care work. If you're not a mental health service, then what you're asking yourself is the question, are unpaid carers frequently involved in supporting the well-being and or treatment of your service users? If the answer to that is yes, such as a paediatric or a children's service would answer, they would deliver a tier 2 carer offer. If the answer is no, which might be the case in sort of services where they're outpatients coming in, who you think it's less of a problem, they wouldn't offer the full tier 2 offer, but would still have staff who are care aware and are offering support and signposting. So looking at once services have determined whether they provide the tier 1 or tier 2 care offer, they would complete a self-assessment. And this involves services assessing their compliance against the standards by completing either the tier 1 or tier 2 self-assessment form. These forms, which are actually in the strategy itself, there's two, then in Appendix B and Appendix C. What these forms contain, they contain essential actions that services must demonstrate that they're doing in order to achieve compliance with the standards, and potential actions. The potential actions are really just suggestions, and it'll be up to the individual services to determine which of these would be appropriate and relevant to implement for them. Alternatively, services could design their own and implement their own actions to ensure compliance with the standards. And if services identify they're not meeting a standard, they will be required to develop an action plan to clearly identify what they plan to do in order to improve their compliance. And the action plan will be recorded on the self-assessment form. So the form then is submitted, so where we get to possible outcomes. This is to seek and gain assurance that the service have taken actions to ensure that they're meeting the standard, and any action plans are robust enough to sufficiently make compliance. The possible outcomes would be that there's sufficient evidence to provide assurance, or there's insufficient evidence or an absence of a credible action plan to provide assurance of how the standards will be met. And this form would then be returned to the service then to amend and resubmit. And the final point there is that this self-assessment process will include time intervals. So the strategy contains many sort of recommendations and actions to ensure successful implementation of it. However, there's priority for the first two that really need to be worked at first, and their fundamentals drive this work forward in the organisation. So these really are that the group is very strongly in the opinion that there needs to be a permanent new role as a trust carers lead to drive this work forward. I attended the London and South East Triangular Care meeting, and it demonstrated how many organisations have a designated carers lead on this agenda. Mental health trusts are definitely further forward on this agenda than physical health trusts or community trusts. But certainly those trusts that are doing really well are the ones who have a designated trust carers lead. So last month I presented a similar presentation to the Quality Assurance Committee, and they supported the need for a carers lead to take this work forward. And I'm currently trying to pull together a JD, job description and personal specification for this role. So the second thing would be, hopefully we get that person in post, and then it's the development of a family and friends carers group who would be responsible to deliver the actions and recommendations made in this strategy. Minimal representation I would recommend would be representatives from all divisions, governors and some carer representatives if possible. So really just coming to the end of my presentation. So in conclusion, sort of the piece of work I did in the review that I did, we've got some really good examples of carer engagement in this organisation, particularly in mental health services. That's where we're doing really well. There's a lot of groups going on where we actually seek actively to involve the carers and actually inform them and educate them as well, and make sure their voice is heard, which is brilliant. But if the trust wants to see further improvements in the carer engagement experience across our services, really these are the next steps we need to do. So from me, that's my presentation. And if you've got any questions, I'm more than happy to answer them.
Dan, thanks so much. Any questions for Dan, please? Julia.
Hi, Dan. Great piece of work. Really interesting. Thank you for doing all that. I think it is clear that we are probably doing less for carers in physical health than mental health, but I think the two-tier structure looks really clear and will help teams to know the next steps that they need to take. So yeah, thank you. I appreciate that.
Thank you.
Thanks, Julia. John.
Yes, thanks, Dan. Good to see this come to conclusion. I remember chatting to you just before you started this, and unfortunately the Maidenhead meeting was cancelled, so I didn't unable to come to that and give any further input. But yeah, it seemed from a brief read, I haven't read the whole thing in detail yet, but you've come up with a series of very sensible moves to take things forward, especially the aligning with what the NHS is trying to guide people, and the trialing of care. I know been to several conferences in the past where we talked about trialing of care, and that's an extremely good, worthwhile system. The carers lead, yes, we've had a go at having a carers lead who does 1 or 2 days a week. I mean, are we proposing, is this job description literally for a full-time role, or is that yet not defined?
At this point, it's yet not defined. What I'm trying to get hold of first is some ideas of banding of these roles, because they're very variable across the country. They range from a 6 up to about 8B. So there's a huge variation in that, and there's a huge variation in time. There's very few that are full-time. Most are around about 3 days a week. That's roughly what it is.
I think sorry, Martin, I think it's a danger in it being too low a band, because they have to have a reasonable amount of authority there. Yeah. So I'd urge towards the 8A sort of thing, if I was doing it, but I'm not, obviously. Again.
And John, Jane, who is my support to doing the piece of work, we've discussed this, and again, to have buy-in, there needs to be a degree of seniority in this post.
Absolutely.
We're in the agreement that the minimum it probably should be is an 8A. I think to get that almost that clout to get people to go, right, this is really important. We're really taking this sensibly in the organisation.
Absolutely, super. Going in the right direction. Thanks, Dan.
Thanks, John. Paul.
Yes, thanks, Dan. We've met before, and I understand and support this activity. It's very important for the trust. I think 2 things that really going back a little bit to first principles. First of all, the trust should regard this as a multiplier of their efforts to produce good outcomes with patients, and that should underline all the priorities, I believe, in relation to how they deal with carers. We do want the best outcomes for patients, and carers are with patients 24/7 in a lot of cases, and they have a big influence on that. The second point I want to make, I'm now looking at page 67 of the governor's papers, but this is your tier 1 offer and tier 2 offer, standard 1 to 3 and standard 1 to 6, and it's very striking that this is not carer centric at all. Every standard begins with the word staff or services, and it's really focusing about our organisation and not what carers will get from the result of this project. And I would urge you, when you take this forward, to really take a bit of inside out thinking and think about what carers get and what is the distinction from a carer's point of view about the delivery from tier 1 and tier 2, because without that we're destined to fail, really. Thank you.
Thanks, Paul. Dan, did you want to come back on that?
Yeah, no, thank you. That's really useful feedback. I think the big thing for us, and that's why it is the first point, that actually a lot of carers don't identify that they're carers. They're just a husband or wife, they're a son or daughter. And actually, I think as a result, the first thing we have to get right is we have to get our staff asking the question, because if we can't identify them, we can't actually do anything to improve the journey for those carers and the support we offer. So that's why it's really key to me that actually the first thing we do is we put it on our staff's agenda, and the questions are asked early in the journey. And if we can do that, then we can address the needs of those carers and have those conversations about what can we do to help you.
Thanks so much. We got three more questions. Isabel?
Sorry, thank you. I'm very interested in this. I was a carer, and I know it's a long time ago, and we started our own support group because we got very little help. But don't forget, a lot of the carers are actually children and teenagers. Are you looking towards giving them support too, please?
Absolutely. So the children's services would deliver a tier 2 offer. So absolutely, we're trying to raise that. I also know a lot of the children's services, and they are doing a huge amount to try and identify those who are young people and who are taking on caring responsibilities, whether that's for a parent or a grandparent or someone or another sibling, it could be. And I know that they're certainly chatting to local authorities. Certainly some of the local authorities have a lot of young people carer support networks as well. So I know it's on the agenda of those services. So hopefully this would only dovetail well with that and actually continue to raise the profile that we don't just think of as a carer as an adult. There are a huge number of children who also deliver really important care and stuff that adults would go, crikey, I can't believe they're providing that level of personal care or support to a parent. So yes, absolutely critical.
Thank you very much. Deborah Edwards. Deborah, are you there?
Yes, sorry, I lost my mic.
Don't worry.
Thank you, Dan, for this report, this strategy. And as Paul has pointed out, I really concerned that the carers' voice is not fully in with this strategy. I was also concerned, having looked through, I know this could have changed, the list on the tax and finish group. There was only one carer on there as a member, and I really would ask you to consider to increase the number of carers. It's not, as Isabel has pointed out, it's not only adults, it's children, and it's also what you call somebody like myself who has had to care for 2 adult children with mental health situations on and off over the last 10 years. So I'm not like I am an unpaired carer, but I wouldn't know anything about this if it came through, because we're informal. It's trying to get this message out that this is for you and helping you and will help you. And I wonder what strategies you've got for getting the marketing and the PR out to people such as myself, and perhaps as Isabel has been as well. Thank you.
Absolutely, thank you for that question. So to answer your points, so the first thing about the lack of carer representation, absolutely. At the point of developing this, we had one meeting and then a huge amount of meetings were cancelled due to COVID, which was not the ideal. And we were looking at having more representative at those meetings. Isabel was one who was due to come to the next meeting as well. So, and I completely agree that moving this forward, there needs to be a bigger voice of carers within it. And that's the recommendations in there that not only have we got representation from our divisions and representations from our sort of our NEDs and things like that, we've also got representations from carers as well. So that's certainly on the list of priorities to have involved with it. Absolutely. I think the thing about carers' involvement in it more as well is certainly the tier 2 offer. The last point on that is about, it's all about carer engagement, carer feedback. So it's trying to then go, what are we doing well? What aren't we doing well? So those services will change, hopefully process, change what they deliver to actually meet the needs of what their particular carers need, because it will be different between a mental health service to a children's service, for example. So I hope as this project moves on and hopefully we get the person in post to lead this, that will morph out of it and carers will have a greater role to play in the development of what comes out.
Thanks so much. Tom?
Just to pick up on the question that Isabel asked about child carers. Now, if we imagine a service might even be a tier 1 service that identifies a child carer, perhaps podiatry or something, identifies a child carer. Are you saying that they will make a referral to children's services? Is that the method you're describing?
Yeah, absolutely. So the third point on the standard is about the. Can we just mute, please? Sorry. So that every service will have staff who will refer or signpost to carers to relevant support. So the idea behind that, my long-term vision for that would be that what we have centrally, so we have now a new intranet, so we have Nexus. So the idea for me there would be, there is no point in reinventing a service directory. All the local authorities have them and they're huge and they need regularly updating. To me, what I want to see happen is that if staff have the awareness because they've been trained, they then know where the person lives. With the consent of that carer, they would be able to either refer to the relevant agency using the information hopefully we will have on Nexus, or they'll be able to give that information if the person doesn't consent to being referred on, and they could then refer themselves. So absolutely see all the staff having a role in making sure that carers get support, because often it won't be health that are delivering that support, it will be social care. So it may be we just have to be able to signpost to the correct people or the correct borough for them to then take it forward.
Okay, thank you very much. Verity, please.
Hi. I think firstly, the real test of this will be whether it actually works and improves things for carers and patients. But adding to what comments other people have made, I think the question for me is whether we will be able to you will be able to identify carers, and being aware of the diversity of carers. I mean, certainly, especially my experiences in mental health, a lot of people with mental health issues act as carers for other people with mental health issues and may not think of themselves as carers. And how are you actually going to unpick that and make sure that the people who probably need the most support are identified and get it?
Absolutely. I think from all the reading I did on this piece of work, the biggest thing that people came back to was that a lot of times people don't identify themselves as a carer. And I think the only way we hopefully allow people to identify themselves is having those conversations, those open conversations at initial assessments, to the point of, are you supported by anybody or do you support anyone else? And hopefully that's where we glean that information. In one of the recommendations I've put is what we need to look at as well is most of our services, not all, but most of our services use RIO as their electronic patient record. And it's about how we make that a more visual alert, because you can record and therefore you can run data reports on how many people are registered as a carer, but it's how we get that more fine-tuned and more transparent and more highlighted on people's records, that when people do come in, we can see that they have identified that they have a care or that they care for someone else. So therefore we can then have those conversations with that patient to say, are you still caring, or has your carer changed? Do you no longer have a carer if something has changed with their health condition? So I'm kind of hoping that's how we will get more carers become more visible because of that.
Thank you very much. John, is your hand up new or is it an old one?
No, it's a supplementary, Martin, over having sort of thought about what Dan said, yeah?
If you could be quick, please.
Yeah, I will do, yeah.
That's all right. No, just
I think, you know, Dan's perfectly right. The awareness is an absolute key, and getting it on electronic systems. Believe it or not, even the GP service is now recognised that my wife's my carer. And, you know, that's massive progress because they've been extremely poor in doing that in the past. So, yes, getting it on the electronic system so whoever picks up can see that information is an absolute key. And that I applaud that, and that should be one of the key aims of pushing this forward. So thanks for that.
Thank you, John. Isabel?
Thank you. Some years ago, I went to the AGM of the Pick's Disease Society, and we had somebody from the National Neurological Society talking, and it was a privilege to hear what they said. And they were a room full of people who were caring for those with Pick's disease, which, as you know, has other associations as well. And they said that we had much more knowledge than they, the experts, had. And I think that was an acknowledgement of how much work and value the carers are. I'd like to share that with you.
Isabel, thank you very much indeed. Well, Dan, you can tell from the questions, this is a really important topic for governors. and as a carer myself, I very much support this initiative, and I think it's great that we're getting a more strategic view. So I wish you all the best in your endeavours, and we'll look with interest at how it progresses. But carers can play a most important part in patient recovery. So thank you very much indeed for that.
Are you happy if I leave the meeting now? If you,
yes, thank you. Thanks, Dan.
Right.
I'm sure you've got more important things to do.
Thank you for your time, everybody. Thanks very much.
Thank you, Dan. The next item is actually reports from subgroups, but I don't think there have been any, so I assume there's no reports unless anyone wants to lead. No? Okay, well, can we move on then to executive reports in the Trust? Patient experience Q1 report. Heidi, do you just want to pick out the key things for us?
Good morning, everyone. You may have noticed I'm not Heidi. Those of you that don't know me.
Oh, Elizabeth, sorry.
Hello. Hello, my name is Liz Chapman and I'm the Head of Service Engagement and Experience for the Trust, and I'm covering Heidi today just to give you a really brief overview of the highlights of the patient experience report for Q1. So it's from page 71 in your pack. Very brief overview, as I say. So obviously Q1, we're in the height of the pandemic. So we did see a reduction in the number of formal complaints that were received, which wasn't unexpected. We did see, PALs shoot up a bit, but we didn't see formal complaints increase exponentially. The Friends and Family Test, so the FFT, was due to go live with a new question from the 1st of April. So we've all been scurrying around in the background, getting ready for the launch of the new question, and then obviously it stopped. So we had permission from NHS England to reintroduce it a bit earlier than they are nationally. So we actually went live from the 1st of September on what we're calling a soft launch of the new FFT question. One of the reasons, or the main reason, that I wanted to adopt slightly earlier before we're into mandated reporting is because, we recognise there's going to be changes to how we collect the FFT due to infection control, for example. So a lot of the ways that we used to do it, we're adapting now. So we're using technology a lot more, particularly through SMS. So that's the real driver for us. Again, it's a non-contact method, but we have introduced infection control procedures for the use of cards and the use of devices. You may have noticed in the report that there's been a reduction in the number of compliments. Now, these are service reported compliments through a system. What we do know anecdotally is we've had such wonderful feedback from people in such a challenging time, and they're included in the report. There's some examples in section 14. So that's page 87. So if anyone's interested and they haven't had a chance to look yet, there's some really good examples documented there on how we've responded to COVID and the impact that's had on the patient experience. So that was really my very, very quick whistle-stop tour. What I would just like to do, if I may, I joined the call a little earlier, and Isabel, I heard your question around the visiting. And absolutely, to echo Julian, it's been, such a challenging time. I've had loved ones in hospital, and it really has been difficult. During Q1, so again, the height of the pandemic, we didn't have a single complaint come through corporately about visiting. In fact, it was the opposite. People saying, we completely understand and we appreciate what you're doing. We did see, obviously, an increase in PALs and people asking about visiting and asking about nuances. Can they do this? Can they bring in that? Most recently, we've had someone write to us about changes to visiting provision during the colder weather, which ties in well with adapting visiting guidance for meeting inside rather than in gardens. And to follow on from that slightly, we've had a real positive unintended consequence, which is the message to a loved one, which is where people can call through to PALS or send us an email, and we've got a template and we type it out, the message, and we send it to the ward and they print it, pop it in an envelope and give it to the patient. And we've had such wonderful feedback. We've had people locally send in messages, but also as far away as Australia, Canada, South Africa. So this is absolutely something that we're going to keep because we can see, there is something about receiving a letter on a ward from a loved one. So that's absolutely something that we're going to retain moving forward. Hope that was okay.
Liz, thanks so much. Any questions from governors? Julia.
Hi Liz, thanks
Hi,
for
Julia.
that. Thanks for that brief overview. That was great. Couple of questions really around whether we've had any complaints around waiting lists, because obviously our waiting lists have increased with lots of services being closed or reduced. And the other question around is around complaints about inpatients on the physical side, because we've changed the way that we work now with the D2A model. Patients are being turned over faster, and I just wondered if there was any theme around complaints around that.
Thank you, Julia. To answer your second question first, no, there hasn't. Which, you know, does quietly surprise me, because whenever we make a change in care provision, and for some people that's a really big change, we've not had that. People have been so overwhelmingly understanding. I'm genuinely shocked. In regards to wait lists, so Q1, which is the report that you've got as part of your pack, we really didn't get that many. What we tended to find was some informal PALS concerns, predominantly actually around CAMS. You know, children are at home with their parents, and parents are using that as an opportunity to say, look, what's going on with this? Most recently, we have seen a few more come through. I think there is that expectation in the community that we're back to business as usual within the NHS, and we know that's not the case. So there is a bit of work we're doing around managing expectation, and also we've changed the way we deliver a number of our services using, you know, virtual appointments, telephone calls, more. So yeah, there are some changes, but we haven't seen a massive influx, which is what I was expecting, but we are seeing a slight increase at the moment.
That's great. Great to hear, Liz. Thank you.
Okay, thank you very much indeed, Liz. Thanks for your presentation. Time is a bit against us, I'm afraid, so we need to move on to the performance report from Julian. Julian, you normally take this as read and with just questions. Are you happy to do that?
Yes, exactly right. Take it as read. Alex has already covered off the finances, remember? That element of it.
Paul.
Yes, I didn't get all the way through this, but I got a bit stuck on question on point 1 or point 2. Talks about the flu virus and how the NHS has an ambition to have 100% take up within the NHS. And I was just wondering if maybe you can answer this, maybe not, Julian. Is the objective to stop staff in the NHS transmitting flu to patients, or is the objective just to keep them at it, keep them working, and not be off sick? Because I think if it's the first, then I'd be a little bit concerned, because in the past our staff haven't taken it up 100% at all, have they?
That's right, Paul. It's all. It's not sort of do this for your own benefit or do this for your patients. It's protect yourselves, your loved ones, and your patients. Is the message. As a mental health and community trust, we have a fairly high take up, consistently over 70%. There's still quite a cohort of staff who generally have been reluctant to take the vaccine, despite all sorts of educational stuff, but still quite a lot of myths and stuff. Some of the best get up to about 80% generally. Now with COVID around, Paul, we expect a more serious take up, and we've employed more peer vaccinators this year, and we've gone for drive-through clinics as well. So we've got 2 drive-through clinics, so if people are worried about getting COVID as a result of that, we're using the same technique as we did for swab testing at Ascot and at West Berkshire Community Hospital. And we've got roving peer vaccinators in all of the main sites operating through the day. So I'm confident we'll have high numbers. There'll always be a few people, I suspect, because you can't force them. It's not a contractual requirement. They may well decline, but I think we'll get into the high numbers on this year.
Okay, thanks so much. I hope all governors have got their flu vaccination arranged. Tom. Tom, you're muted. What's up?
Sorry, it took me a bit of time to unmute. There's a lot of discussion about mental health in the public due to in lockdown, and I see we've got a number of suicides in the safety report. So I wonder whether you could sort of just give a look at whether you're seeing a lot of disturbance and we're really feeling the affecting the general population of the lockdown and economic disruption?
We haven't seen a noticeable increase in suicides at all yet, Tom. That's kind of noticeable. But what we have seen is in the middle of the summer, we started to see presentations of mental health acuity from people that had previously no contact with mental health services, which was a national trend. People very worried, often quite paranoid, and getting admitted. So obviously being quite well at home, and because they'd not previously been known to services and maybe not accessing the GP at the time, there was quite a lot of people. So that was quite a challenge. People we didn't know, very seriously unwell, and getting admitted to hospital because they were so unwell on presentation. So that was certainly a new phenomenon for us. That sort of settled down a bit, but obviously that when activity picked up in May, June, July, that was quite a feature. As for the economic hardship, there's probably a lag to that in terms of we don't know quite what the response will be to COVID itself. No one does. There's various modelling goes on, and they're saying different things depending on who does the modelling. But we do know the impact of recessions. You know, we know the impact of what that does for mental health and suicide rates, and it does sort of drive that up. So as we end the furlough scheme, as people start to get paid redundant, and we start to hit, you know, the reality of the recession and the winter months, we might be able to start to see that sort of come through. We do expect our talking therapists to pick up the majority of these. This is, you know, the biggest service that sees the majority. Last year, talking therapists saw 1.2 million different people. It's going to go up to about 1.5, 1.6 this year, and our service is geared up for a 20% increase in activity in terms of staffing and increasing staffing to be able to deal with that. Whether that be enough, who knows, but we'll certainly see an increase, Tom.
Thank you very much.
Guy?
Good morning, thank you. I've got a couple of points, please, on the performance report. I noticed that the numbers of, on page 96, I noticed that the number of assaults patients to patient has actually increased to 60 over 46 from the previous quarter. That's away from our target and is contrary to the commentary. The second point I was going to ask about was the staff sickness, because I noticed for the quarter one is exactly the same percentage as for quarter four of the previous year. And I'm just wondering whether for quarter one, maybe it was an estimate or some other measurement, please.
Thanks. So some points of accuracy to correct in terms of narrative and bar chart. So Alex can actually is still on the line to pick that up, so we correct it for next time, and we'll look into the staff sickness. And perhaps via Julie, Alex, if you could just get a note back out to Guy, so you don't have to wait for the next meeting to see if we got that right.
Will do. Thanks.
Thank you.
Okay, thanks so much. If we could, then we move on to the COVID-19 recovery update. And Catherine, I think if you're on the line, over to you.
I am. Thank you, Martin. Thank you very much. This is page 105 in the pack. I'm going to take it as read. There are a couple of updates I'd actually like to give, and then I'm very happy to take any questions or any comments. What I'd like to do, though, first is call out the absolutely fantastic work that staff across BHFT have done during this period of work. In terms of recovery and restoration, all of the community health services are operational again. They're operational predominantly in what we call a blended model. So you've heard Julian talk earlier about the mixture of remote working, telephone triage, digital opportunities. So most services are now offering a range of ways to access their services. The vast majority of mental health services are now also operational. I have 4 that are outstanding to be approved, and they will be approved within the next couple of weeks. We fast-tracked what we call the service prioritisation, i.e. looking at the services to be opened up again as the first part of our recovery, and that's finished. We are now moving into the next phase, which is very much around capacity modelling and demand. So we've established where we're building a capacity and demand tool, so we understand what it would take to be able to reduce some of the waiting lists that have increased during this period. So we'll be able to have the conversations with commissioners that we need X number of additional staff or X number of additional clinics to be able to clear that backlog. So that's all in hand. So that's all very positive. It's going very well. What I have updated, which you haven't got in the report in front of you, is the potential impact of the second wave. So we are modelling and we are keeping a very close eye on what's happening. But of course, it's a bit unknown, depending on the extent of the second wave and what impact that will have on the speed of recovery and restoration of our services. So at this point in time, we're aware of that, and we're just very much keeping a watching brief, which is all we can do at the moment. Operationally, we've designed and completed what's called heat maps. So we have a very clear picture of all of the services, the waiting list for all of the services, the impact of staffing on services. So that's a really important operational piece of work that's been completed. And then the only other thing, I guess, to add, there was a question in an earlier meeting. HR are currently having conversations with some staff groups such as MSK, and we're looking for volunteers just in case the worst case scenario happens in terms of wave 2 and we do have to move staff around. We're not intending, unless we're mandated to, we're not intending to do mass redeployments as we did before. What we're doing at the moment is building up a bank of volunteers who would be prepared to do extra shifts if it's required. Hopefully it won't be, but that's just our plan B. So they're just the additional bits I thought would be really helpful to update everybody on. I'm very happy to take any questions and comments as required.
Thank you, Catherine. Important and complicated business. Questions from governors, please. No, no questions. Okay, Catherine. Oh, sorry, Paul Meisco, and then John Barrett. You're on mute, Paul.
Sorry, I was on mute. Yes, I'm a bit interested in the. I mean, we talk about waiting times, and there is a backlog of patients waiting for some of our services. But my understanding of waiting times is this translates into additional costs to the trust. And do you have a view on the position regarding extra funding to cover this extra cost, which is a result of our new way of working?
It's an interesting mix, actually. So some services are experiencing longer waiting lists, but actually some services were able to clear their waiting list during the COVID pandemic because of the accelerated use of digital ways of working. And it's something we need to model. There will be a number of people that we will be able to clear from a waiting list digitally, and that actually uses less clinical time than a nurse, for example, having to travel across Reading to see a patient and do that triage. So it's an interesting mix. It is included in the capacity and demand modelling tool that we are developing at this point in time. So although I know it's a question that I need to answer, I don't have a specific answer at this point in time, but it is included in the model that we are working on.
Okay, thank you. John Barrett.
Yeah, I think Catherine's almost answered my question, Eric, because it was similar to Paul's about services and waiting list things. But does this imply, Catherine, that there hadn't been a central listing before of waiting lists, or have I just misunderstood that this is what you're doing is an extra part of planning to sort of see where we are now?
We've always known what our services waiting lists are, and a number of those will be national performance KPIs that we report against. You'll probably be aware that some of that reporting was paused during the COVID period. So what we're building up is a picture. We understand pre-COVID what the waiting lists were. So, for example, IAPT and CAMS are examples we often talk about. What we've now got to layer on top is the impact that COVID has had on that. And that's the work that we're doing. So the model will give us an understanding of services that had waiting lists pre-COVID, Some of those waiting lists have now been reduced because people have accelerated digital opportunities, so that's excellent news. But some of the services have seen an extension of their waiting list simply because they are reliant on face-to-face, and we've had to pause some of that. So it is a complicated picture, but I'm very happy to try and keep it as uncomplicated as possible and give you updates as and when required.
Thanks, Catherine.
Thank you very much, Catherine. Thank you for your time, Catherine. And I think it's really important the governors are briefed at appropriate times on the recovery. And I know it's a very complicated business, and thank you to you and all the staff of the Trust for what you're doing. It's fantastic.
Thank you.
Can we just move on to a bit of formal business now with Julie, the appointment of lead and deputy lead governor?
Yeah, it's just to formally ask the council to approve the reappointment of Paul as our lead governor and the appointment of Susanna as our deputy lead governor.
Can I take that as accepted?
Yep.
Oh, Jenny.
Yeah.
Jenny. Oh, yeah. OK. Everybody seems happy. Good. Congratulations then to you both. Nearly at the end of the agenda, chair's activities. I wasn't going to spend a lot of time. One of the things that's difficult is, of course, visiting. I did manage to do a visit to Prospect Park at the end of July and go around the wards, community and mental health wards, which was very reassuring. A lot of the other time is about strategy. We had an extra board in August for talk about strategy, and we're talking again in October. I've also spent quite a bit of time talking to various people who are involved with BAME staff and also NEDS, so trying to learn as much as I can from the various initiatives going on, and in particular about NEDS to try and find ways of encouraging more people to put their names forward to become potential NEDS. So that's been one of the things I've been doing over the summer. There's been lots of team and Zoom meetings with various other NHS bodies, which is sort of interesting at times. It's not always that interesting, but it's good to make sure we haven't missed something. And I've set up, as you'll be aware, Governor coffee mornings at the suggestion of Paul. So monthly, I'm afraid there's no coffee or biscuits, but monthly I'm available to meet with as many governors as you wish to talk about whatever you wish to talk about, as a way of keeping in contact during these remote times. So that's sort of the things I've been up to other than the normal. There's a governor feedback session. I think because of the time, unless there's anything particularly governors want to raise, I suggest we don't dwell on it. Anything particular? No. Okay. Any other business? Okay. Just to say, just in closing, I'm very keen that this remote working, that we try and use the technology to reach as wide a range of people as we can, both as members, but also as potential new governors, to get as much diversity as we can. And I look forward to any suggestions you've got about how we can make that work better. And finally, I know we've said it a lot, but I do want to thank the staff of the Trust. They've done a fantastic job during these recent COVID-19 times. And I think the excellent foundations have been put in place, recognised by the CQC Outstanding, have helped a lot towards that. So thank you to one and all in the Trust. I think that's then the end of the meeting. Date of next meeting is the 4th of November, joint Trust Board and Council of Governors, and the 2nd of December, the formal council meeting. So with that, thank you very much, everyone. Have a good day.